Hi, my name is Tianyu Shea. I'm a third-year medical student at the New York Institute of Technology, and you're listening to Do or Do Not. Welcome to our 5th episode. Today we have a very special episode where I will interview Dr. David Elkowitz. Dr. David Elkowitz comes from a line of physicians, with his father being one of the founders of NYITCOM. He trained as a pathologist and found early on in his career that he had a passion and skill for teaching students. For years, he was a professor at NYITCOM and was ultimately recruited by the progressive Zucker School of Medicine at Hofstra University. Zucker is an MD institution where he now holds the title of Associate Dean. Dr. Elkowitz wins teaching awards almost yearly and has inspired and mentored thousands of students over the years. I felt it a privilege to interview him and found it one of the most inspiring to date. We will speak to Dr. Elkowitz about his journey from an anatomy teaching assistant at NYITCOM to teaching consultant to MD and DO schools. We will ask him for insight into what the change of Step 1 to Pass-Fail means and what he thinks its effect will be on osteopathic medical students trying to get into a residency. He will also comment on how he feels medical education will be affected by the COVID-19 pandemic. We hope that you enjoyed this episode. When and how did you become interested in medicine and decided that you wanted to become a physician?
It was a pretty serpentigenous route. As a kid, even going through college, I went to a military college, so I certainly didn't have medicine on my radar. That being said, I come from a family of doctors, 3 generations of doctors, and I think a total of 7 or 8 relatives in medicine. So it was always probably in the back of my mind. And as I progressed through life in my early 20s, I started to investigate, well, maybe this is something that I should pursue. Started to retake some science classes that I didn't take in my college years. And, with a little maturity, a little perspective, became very apparent to me that I actually enjoyed the science, when it's something's not forced down your throat, but you actually do it for yourself. Started to enjoy it. And my dad was an osteopath, gerontologist for 45 years. He actually headed up the Allopathic Gerontology Society. So he graduated from Chicago. So, growing up, I never actually kind of made the connection between MD or DO, because my dad, as a DO, had a thriving practice, had an appointment at downstate and, with all these societies. So it never really occurred to me the difference. It's the same thing as going to your dentist. Do you know if your dentist is a DDS or a DMD? I'm not really sure anybody actually cares, or certainly I didn't. So when it came time for me to apply to medical school, applying to a DO school or an MD school, in my way of thinking was essentially the same. I didn't see much of a difference. The end result would be becoming a physician. And, interestingly enough, it wasn't until I entered the DO school is when it became apparent that there was such a seismic difference, at least in the perception. But it took me to become a student in the DO world to realize this perception, because as a person outside, I didn't see it. And then, the rest is history. So that was kind of my journey into medicine.
Can you speak a little about your father and your family's influence on you becoming a physician?
Yeah, I would say that, there's a chronic and an acute answer to that, right? The chronic answer would be that, coming from a family of physicians, whether it's my dad, my grandfather, my uncles, my cousins, medicine was the trade language that was always spoken about at gatherings, going into a gathering, hearing Dr. Elkowitz and 8 people are answering. This was a kind of a chronic thing that I grew up with. I think that my dad, who was a DO and very, very successful, very, very burgeoning practice, really had a great influence on kind of the way I looked at medicine. I originally went thinking about going to medicine as a family doctor, working on one of my ranches in primary care. My grandfather, on the other hand, an MD, and had a flourishing practice as a radiologist, and was also involved in academic medicine as well, and he had a tremendous amount of influence on me as well. So I kind of feel blessed in a way that I had influence from an MD and DO. I had influence from a clinician and a diagnostician. And I've also had influences, chronically. It's just going through life and seeing how my family interacted with society and their colleagues was
Kind of just ingrained from you, like from an early point on. Gotcha.
exactly.
So what made you ultimately choose NYITCOM?
Well, that's actually pretty easy. As many of you, applied to many schools, got interviews, many schools got accepted. And there was just a question at that time, it was called NYICOM. And my family's from the North Shore of Long Island. I had a lot of support. I knew the campus well. It was only 7 miles away from my house. I passed by it constantly. So when making the final decision, it was kind of a no-brainer for me that it was so close to home. I had all the support that I needed at home. I lived at home at the time. The fact that I knew the campus so well, I used to drive past it going out east, took away a lot of the angst that a lot of students coming from other places have trying to figure out the campus, trying to figure out the community, trying to figure out all the other stuff, non-academic. I didn't have to worry about that. So when I came on board the very first day, I hit the academics running. I didn't have to kind of get myself acquainted and looking for housing and looking where to go for lunch or whatever that was. I kind of hit the ground running. So there was kind of a no-brainer for me.
I understand.
And then the other thing is my father had a lot to do with at least the thought behind NYICOM coming to fruition. I think NYICOM started in 1978, 77. And my father and a lot of the DOs of the 70s had a lot of say into putting NYICOM on the map. So certainly there was a family background as well.
What was your experience after you got into the school? I know you mentioned that you didn't realize there was even a discrepancy until you became a student. How was your overall experience at the school, and what are these things that made you realize that there was a discrepancy?
Well, I think that what ends up happening is that students have friends at other institutions, and you start comparing your curriculum versus theirs, what you're doing, what they're doing. You start understanding what's actually out there in the community as far as opportunities for MDs, opportunities for DOs, the separate residencies at the time, the separate fellowships at the time. It became very apparent to me that there was definitely a separation. It certainly was a lot more integrated 25, 30 years ago than even it was back in the 60s when my father went to medical school. But that being said, it was palpable as far as that type of separation. But as far as my education, there was a very traditional type of education, very, very lecture-based, second-year systems, first-year general, concepts. The class at that time was probably about 130 students per class, which I understand is probably small compared to what NYITCOM has today.
Yeah, it's like 400 to 500.
Yeah. So it was definitely a much different field than it probably was today. But it was good. And, I enjoyed my time there. I learned a lot, and I credit NYICOM for giving me the opportunity to become a physician and to make the most out of my career as I can.
That's great. We'd like to reaffirm for a lot of the people listening, the students, the pre-meds, that there's very little difference in the quality of education between these MD and DO schools. Did you do any extracurriculars, anything like research, or any special people that you met in the school that, influenced you a lot?
Well, it was a very traditional setting. So there was of course there was student affairs, but this stuff took really a backseat to essentially delivery of content. I was an anatomy fellow. I spent an extra year at NYICOM, essentially TAing in the anatomy lab, in the pathology labs, in the histology labs. I was the first anatomy, just a little trivia, the first anatomy fellow NYICOM ever had. Now I understand that they morphed into a whole master's level, fellowship program. That's a wonderful thing. So I spent an extra year teaching, and that year, really influenced me as far as the trajectory of where I wanted to go for my career. I would say that year, that fellowship year, was probably the single most significant thing to happen to me at NYICOM.
And would you say that year helped you decide that you wanted to pursue a career in pathology?
Yeah. Oh, no doubt about it. You have to understand, back then, we're talking about 30 years ago, people went to DO schools not to become pathologists. In fact, I would say people go to medical school not to become pathologists. Pathology, maybe 2-3% of the class end up going into path, but certainly in the DO world, especially back then, it was very primary care centric, very primary care oriented. And so for me to actually pursue pathology out of NYITCOM back, thinking about it, 96 and 97, was, really, really big deal. I say 30 years ago, really meant about 25 years, when I first started medical school. So I think that year was a very significant year, as a turning point in the way that I wanted to approach and practice medicine.
And what about that year exactly made you want to do pathology?
Well, so I kind of backed my way into pathology. That year was a very heavy teaching year. I taught in every anatomy lab. I taught in every histology lab, in every pathology lab. It was very, very influential with the student body as far as not only teaching and facilitating learning from the learners, from those students, but also learned assessment, learned mentorship. So there was a lot of stuff that I learned academically in that type of environment. I excelled at it. I loved it. And then I started to think to myself, well, if I really wanted to make this a career, how can I become marketable? If I went into a clinical-based type of profession, at least the way I was thinking, yeah, I'd be able to practice internal medicine or pediatrics, family medicine, but would I be marketable to be an instructor in the first 2-year curriculum at a medical school? And so then I started to think, well, what residency would be most applicable for me to be able to come back and teach in the first 2 years? And pathology was kind of a no-brainer. As a pathologist, I was qualified to teach, histology, pathology, anatomy, some phys, and also as a physician, understanding how to correlate that with the clinical skills. So it was kind of a no-brainer, and I'm happy I went with my gut instinct on that.
What about after that? What was your application process to residency like, and how did you ultimately decide on your program?
Well, so application process back then was very different than the application process now. Back then, the application process was really predicated on you showcasing yourself during these showcase interviews. So, in your 4th year, you essentially have a series of electives. Back then, we were encouraged to, take an elective at a place that you were thinking or that you wanted to apply to as far as a residency. So we did that. And I did that. I wanted to stay on the North Shore of Long Island, so I applied to and did electives at Stony Brook and Winthrop and North Shore and LIJ, some city hospitals, that type of thing, just to make sure that I had the best shot at showcasing myself and coming on board. The other part of this is that I applied to MD residencies. Back then, it was very highly encouraged that we do an osteopathic internship and then pursue whatever you wanted to do. I went right into an MD residency, which, one, there wasn't many DO pathology residencies to begin with. So, it's not that was a dig at the DO profession. There just wasn't a lot for me to choose from, certainly in this area. But there was a very big advantage because I was able to sign out of the match. I didn't have to wait for match day. Back in those days, that if the program after that month liked what you brought to the table and you liked that program, they literally offered you a contract. They offered me a contract that very last day of my rotation in October of my last year. I signed it, and in October of that last year, I knew exactly where I was going to be the following year.
Wow, that's crazy to think about, the comparison between now and then. That's very, very, very strict, very, institutionalized, very regimented. Wow.
Well, I think it's going to eventually go back that way, with the changes of the USMLE, where it's going to be pass-fail. It's going to eventually work its way back to that whole idea of showcasing and really showing your stuff on the clinical round and making those personal connections, rather than the way it has been. Essentially, the USMLE score is the gateway into certain residencies. I think that one of the advantages from getting away from that is that you're going to really put an emphasis again on the rotations and on your personal connections that you develop.
Since we're on the topic, I was going to talk a little about that at the end, but since we're on the topic right now, you don't think that it will just change from a heavy emphasis on step 1 to step 2 CK instead?
Well, I think short term it probably will. But I think that the trend, this is just my opinion. I don't have any insight, and if I did, I couldn't disclose that to you. I would say that the trend that I feel is that these steps are going to be competency-based steps that essentially end up in a licensure. I think that step 2 eventually will go to a pass-fail, but that's just pure speculation. I don't know that for a fact at all.
Yeah, I just want to talk a little bit more about that at the end, if that's okay with you. I wanted to ask, how would one choose between a small or large public or private institution to go to residency?
Well, so every residency is very, very different, right? In other words, you have academic-based centers, you have community-based centers. You have academic centers that have a tremendous clinical type of population. You have academic centers that put a lot of emphasis on research and academics, didactics. You have community hospitals that don't have a tremendous didactic presence, but have a very robust hands-on experience. The other point that, obviously that goes into play is where you eventually want to move and settle. Quite often you make a lot of your professional contacts during your residency. So if you wanted to settle in an area, it would behoove you to maybe do a residency in that area. You don't have to, obviously, people travel, but that was part of my thinking at least. So, how I picked the residency is first, what was the area that I wanted to eventually settle in? And, if I wanted to settle in the North Shore of Long Island, which I am right now, I'm in beautiful Smithtown, New York, right outside here, you can see the Nessequag River.
Beautiful area.
Yeah, so, I think that played a big role. But the other thing is that I wanted to make sure that in my personal experience, that I get enough clinical, meaning enough specimens that I'm actually grossing and reading out to at least have a lot of anecdotes in my arsenal, if you will. So when I am working with students, I can actually bring these examples into the classroom. So that was one thought. I also wanted a residency that did emphasize teaching. North Shore at the time, now it's Northwell, emphasized teaching. The very first week that I was there, I was running medical mortality rounds. Every week there was 2 or 3 teaching sessions with residents from different departments, which I became in charge of. I enjoyed it, and it was a really nice fit. So I think the answer to your question is you kind of have to work backwards. If, for instance, you want to be a clinician that's seeing a tremendous amount of patients, then I think that you have to go to a residency that's going to afford the opportunity for you to see a lot of patients and get the most experience. I think that if you're a person that wants to go into some type of research or academics, then you might want to look at a name. You might want to look at the different types of grants and research going on at that institution. And I think that, if you really are hardcore wanting to settle in, for instance, Southern California, then it would probably behoove you to look for a residency in the area ultimately that you want to settle in. You don't have to, but I think it's going to be advantageous because, again, if you're going to spend 4 or 5 years in a residency in an area with a fellowship, you're going to develop a tremendous amount of contacts. And that's how I would go about approaching that.
Thank you. Yeah, that's really useful. What was your residency experience like? Do you have any, highlights during this that you would like to share with us?
Yeah, no, I think that it was a wonderful experience. They really gave, the residents, that they can earn the attending's trust, a lot of autonomy in grossing specimens and signing specimens out. I was blessed to be working with a guy named Stephen Haidu, who is considered the Babe Ruth, if you will, of soft tissue pathology. He was the chair at Memorial Sloan Kettering and then worked his way over to Northwell at the end of his career. I spent a lot of time learning from him. Had a lot of funny stories about as far as, having very big ovarian cysts. I would always, very early on, I'd go in with a shirt and tie and everybody would be laughing when this cyst came down. I was oblivious. I cut open the cyst and the whole thing spilled all over me. So last time I ever wore a shirt and tie, I was in scrubs. I had surgeons yell at me as a resident. And then when I became an attending over there, I had the exact same surgeon yell at me for a different reason, and we became very, very close. all of us surgeons and the pathologists. It was a very, very nice experience. Listen, I spent 4 years as a resident and a year fellowship in SurgPath over there as well. And, they also gave me the opportunity to go back to NYITCOM at that time and teach. So at that time, NYITCOM had a pathologist who I would fill in for as a resident. And to make a very long story short, I think that the students appreciated the type of approach that I had in the classroom. And after my fellowship, I was offered a full-time position as an assistant professor over at NYITCOM. And that really started my academic career.
Did you experience any differences being an osteopathic physician in an allopathic residency?
Not at all. I think that that's very easy for, I'm going to be very, very careful the way I phrase this. I think that if you're looking for an excuse that somehow your career is not going right, or somehow you're not advancing fast enough in an academic setting, it's very easy for a DO to say, that's not happening because I'm a DO. I am sitting here as a great example of a person that took proactive measures in an allopathic institution to succeed in that institution, for them to retain me as a fellow, for them to retain me as an attending physician at the end of the training, for me then to go to NYITCOM, and then when Northwell opened up their medical school 10 years ago, for them to, basically give me a call and say, hey, listen, would you, head up our case-based curriculum, at least help us develop that, and then finally become dean or an associate dean at an allopathic institution. I think that I'm an excellent example of your hard work and your credibility, your knowledge, your tenacity will ultimately dictate your career. And if you wanted to use the excuse that I'm a DO because you're not going far enough, I'd probably say, stop that, look to what you're doing or not doing, because that's probably where the real answer lives. I just have never, I've been practicing now for 22 years. I have never once, not once, ever experienced any type of holding back because I was a DO. And then just to kind of put some more meat on that bone, over the last 5 years, I had offers from the University of Texas, Dell School of Medicine, from Texas Christian University, from Dartmouth, other institutions that have gave me firm offers to be one of their leaders on a dean's level at those allopathic institutions. So, I have just never seen any evidence of, some type of approach where I got held back because I was a DO. If anything, I don't think people ever gave a second thought.
I really love that answer, and I hope the pre-meds that are listening to this, or people who are yet to go into college and they hear this, that they really give a hard second thought about going to these osteopathic schools, that they're, it's really, you can do whatever you want to do.
Well, listen, you guys are very lucky today. If I'm speaking to a pre-med right now, and I counsel a lot of pre-meds looking to go to DO or MD schools, back in my day, the question really was, should I go to a Caribbean school or should I go to a DO school? And back in that day, the answer wasn't as easy as it is today. Because back in those days, the residencies were separated, the fellowships were separated, and so essentially the path that you wanted to take was really predicated on, in large part, the medical school you ended up with in that degree. So, today, on the other hand, the answer is completely opposite. It's a no-brainer. The fact that the MDs and DOs have unified their residencies, have unified their fellowships, essentially GME is completely unified, makes going into an MD or DO school, the choice is an easy one. And in fact, many people apply to MD and DO school simultaneously now. It's the fact that they unified the GME, the fact that you see leaders, DO leaders in allopathic medical schools, I'm an example of one, kind of makes that choice now not a big one.
Do you think that trade-off is worth it? Because in the past, osteopaths could apply to allopathic residencies, but MDs couldn't apply to osteopathic residencies. But now our DO residencies aren't just limited to us anymore.
Listen, my personal opinion is that unification is good. I understand that there'd be some DOs that actually disagree with me on that for various reasons. But from my point of view, speaking as a physician, speaking as an academic physician, speaking as a person that works in an allopathic institution, at an allopathic medical school, I welcome that unification. But what that really means, though, is that it's going to be up to the it's going to be up to the DO medical schools to make sure that they're keeping pace with the type of curriculum, with the type of education, with the type of competencies, along with the MD schools, because now their students are directly competing with these MD students. And I think that just rises the excellence across the DO landscape. So from my point of view, I think it's a wonderful thing that it's unified. And it really puts, again, the control back into the student's hands. If a student wants to work hard, if a student wants to be tenacious, if a student wants to have a good attitude, which means working diligently with a smile, if the student does all of that and the student knows knowledge, right, has knowledge, then the student's going to be able to basically write their own ticket. But any student that wants to take a shortcut and then use that whole DO label, it's just never going to work out for them.
I like that answer a lot. Thank you very much, Dr. Elkowitz. Moving back to you for a little bit, did you take any loans? And do you have any advice for the students that will and have loans?
Yeah, so no, I did not take any loans. Partly, I was blessed with a family that could support me. The other part of it is that, being a anatomical or the scholarship program, the last 3 years were paid for anyway. So I didn't have to take loans. I lived at home. So no doubt, truly blessed. Now, how would I advise? I guess I have to kind of ask you a question. Am I advising a student that's already in medical school with these loans? Or in other words, how do you want me to address this question?
Both ways, if you like, like in both instances for a pre-med and someone who's in medical school, I guess.
Yeah, okay. So the pre-med, I'll take first. I think that, if you look at medical school, the vast majority of medical schools is an opportunity to become a physician. And you really hold all the cards as far as what you're going to get out of any medical school. I would go to the option that gives you the best deal, MD or DO, period. If you're comparing one MD school with a DO school and all things being equal as far as reputation or whatever it is, I would just go to the most inexpensive option with the understanding that it's your hard work, it's your tenacity, it's your good attitude, it's your knowledge that ultimately will decide if you're successful or not. So that's how I would answer an undergrad. As far as somebody already in school, that's a little bit harder question, right? Because now you're already in the middle of it. You're accruing loans, and that's really going to dictate what is going to happen moving forward as far as residency and fellowship and how you're going to practice medicine. I think that that's going to be a very, very individual thing. I will say this, though, that success in any field that you go into is predicated on your enjoyment. Let me repeat that. Success is predicated on your enjoyment with the content of that field. That's maybe the most important thing I can say to a current student now. So let me give you an example. If, for instance, you thought that a cardiovascular surgeon, as working as a cardiovascular surgeon, you're going to make a tremendous amount of money, or an orthopedic surgeon, you're going to make a tremendous amount of money, and that is the reason why you went into that field, and that's the only reason why you went into that field, you're not going to be as successful as a family doctor that went into that field and they loved what they did. Patients sense if a doctor went into a field for the right reasons. Patients sense if a doctor truly loves what they do or they're doing it for another reason. And the person that's doing it for another reason will never be as successful as they want to be. So happiness, falling in love with the content of medicine, whatever it is, in my case, it was pathology, falling in love with pathology ultimately made me extraordinarily successful in my career. One, my colleagues sensed that I loved it. Two, my patients did. Most importantly, my students did. So with that begets institutions going, well, we want to have you here. We want to have that type of atmosphere. We want to have your expertise at this school, at that school. And in my particular case, it worked out wonderfully that because I love what I do so much, I never was hard pressed with being successful on that front, on the financial front. But it's because I fell in love with the content of teaching and of pathology. So I would advise you that I know that residency is a big thing on your minds and getting reimbursed and making sure you pay down those loans. But the easiest way, I think, to pay down those loans is to fall in love with a subject matter that's going to make you the most successful.
I think that's very important for a lot of students to hear, because I personally know plenty of students who are doing something or applying to something that they don't necessarily like just because they're afraid that they can't pay back their loans. And I think that's very important. Yeah. So I understand that you said after residency you were offered a job at NYIT, but how was your experience looking for a job other than that? How did you choose location, practice, hospital, and what were the pros and cons of your choice?
Well, again, I worked backwards, right? If I knew I wanted to go into education, I kind of made sure that whatever I did set me up for the next step. In other words, I just didn't go through my career like a leaf blowing in the wind. I had complete control over what I did. So, in other words, as a pathology resident, as a pathology fellow, I taught, substituted lectures at NYITCOM during those times. I've already set myself up to transition from the hospital to the classroom during the time of my residency. I set myself up with the knowledge of pathology during my time of residency. So when I made that transition into teaching at NYITCOM, it was a very seamless type of process because I've been doing it anyway for 4 or 5 years, backing up as a resident and fellow. So for me, it was seamless. It was not one of these things where I had to really sit there and think to myself, do I want to do this? For me, getting a job was never really an issue because I think that I always loved what I did. And to this very day, when I go on talks nationally, for medical education talks, I have never had any problems getting offered positions or having opportunities in front of me. And when I say that, I wear my DO degree with a lot of pride. In other words, if you were to come to my office at Zucker School of Medicine, right outside my office is David Elkowitz, DO. On my lab coat, when I teach Zucker School of Medicine students, it says David Elkowitz, DO, Associate Dean, such and such. So, I never hid behind that. I'm very, very proud of my experience, my degree, and the transition from residency to getting a position or a job academically, it was never an issue. But I would say that you have to proactively think about the next steps. So as a resident, what I would tell you is don't only look at the task at hand, but try to look at where you want to be in a year from now. How do I get there? Take proactive steps to get there and not be so reactive.
If you had to choose another specialty, if you had to go back in time, can't do pathology, which one would you think that you would end up doing?
Well, I laugh because this actually, I tell a lot of my medical school students this story. It's about attitude. The story is rooted in having a good attitude. So back then, and I'm sure it's the same now, in my third year, I just was terrified and did not look forward to my OB-GYN clerkship. Just wanted no part of it. Back in those days, I was at a public hospital, extraordinarily busy. We had 36-hour shifts, a day off, and then come back for another 36 hours. It was just absolutely brutal. And that was for 6 weeks. And I remember thinking to myself, I'm not going to be able to change this reality, but I can control my attitude. And I remember stepping foot in the doors of the hospital the very first day, and I said to myself, either this is going to be the worst experience of my life, or I can make this the best experience of my life. I chose to make it my best experience of my life. I threw myself in it. I proactively had a good attitude and threw myself into the rotation. I went up the elevators. I wound up on the floor. I said, I want to be in the very first delivery. The nurse in charge was going to room 12. You'll meet the midwife in there. And from that day on, I didn't transition into it. I didn't take a tour around the hospital. I didn't look for an excuse to get off the floor. I didn't hide in the library. I threw myself into that rotation. It turns out that through this whole idea of having a good attitude and throwing myself into this rotation, it dawned upon me that I really was good at it and I enjoyed OB. And I really thought very long and hard about maybe going into OB. So the very next year, I did a sub-internship in OB at the same place, and they offered me an actual residency. And at the time, I turned it down, and I'm happy I did, because I really wanted to go into academics for the reasons I talked to you in pathology. But it's a very good example of how what I thought was going to be horrible turned out to be one of the greatest experiences of my life, just because of a change in attitude. And to answer your question directly, if I wasn't a pathologist, I'd probably be an obstetrician.
So then, with that being said, do you think that the success in your, medical career is secondary more to intelligence and hard work, or to luck?
Persistence, 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 coupled with a good attitude. Period. It's as simple as that. It had nothing to do with luck. There's no question about it that God played a big role personally and professionally in my life. But that being said, so I don't consider it luck. I consider it maybe God's work. But that being said, you kind of have to meet God halfway, at least in my particular case. And if you're going to wait around waiting for a good break to happen, it's never going to get there. If my career tells you anything, I'm a plotter. In other words, I kind of plan a year or two in ahead every step of the way. I mean, my career is riddled with these examples of something that I did today translated to something else a year from now, and something else from a year from now translates to something else. My career is riddled with that. So no, it had nothing to do with luck. It had everything to do with persistence, good attitude, knowledge, and making a plan and sticking with it.
Very inspirational, doctor. You make me want to go open a book right now.
Well, you should, because listen, great doctors have to fall in love with medicine. Great doctors have to fall in love with the content of medicine. So you have to fall in love with the content of what you're going to practice, and you have to fall in love with the practice of medicine. And if you don't fall in love with those two things, you're not going to be as successful as you want to be. You have to allow yourself to fall in love with it.
Is there any other advice besides what you said already that you would like to give to medical students or pre-meds, anyone who wants to do medicine for a living?
Well, I would say that when you're thinking about not studying something as hard as or deep as you should, what I always advise my students over at Zucker is just pretend that you have your future patient sitting on your shoulder. If they saw you essentially learning dilated cardiomyopathy through a USMLE review book versus learning about dilated cardiomyopathy from Robbins, they're going to make certain judgments about you. So the reality is that I think that, you have a responsibility to learn as much outside of what you think the instructor is going to test you on. You have a responsibility to your future patient to learn as much about that material as possible.
Moving on to a few different questions. I understand that you're the dean of Hofstra Medical School. Do you find it interesting or even ironic that you're a DO dean of an MD school?
Not at all. Back way before your time, I directed the problem-based learning curriculum at NYITCOM, the DPC. I was a director of that back in 2007-ish, somewhere around there, 2006, somewhere around there. But before that, my approach to medical education was, all right, you're going to sit there, I'm going to lecture to you, and you're going to remember everything that I said. I had a mentor at NYITCOM, he passed away, but his name was Ron Portnova, and he brought in problem-based learning from Ohio. He was Case Western trained, PhD, and he was one of the associate deans at Ohio back in the early 2000s, and he brought problem-based learning over to NYITCOM. He suggested, it was a very funny story, and I'll tell you that in a second, but through a series of events, I started to facilitate the DPC, became good at it, bought into it, and next thing I know, I started to direct the curriculum over there and did that for about 4 years. Back in 2009, or I'm sorry, in 2007, 2008, Hofstra and Northwell at that time were having discussions on opening up their own medical school. In 2009, 2010, I found out that the school that they were going to open had a case-based or DPC-like curriculum there. And the next thing I know, they brought me on to help them develop their case-based curriculum. I developed it with others. And then, through a series of hard work, I not only directed the case-based curriculum over there, what we call PEARLS, you call DPC. We call PEARLS, Patient-Centered Exploration and Active Reasoning, Learning and Synthesis. That's the acronym for our case-based curriculum. We started to really, really excel and attain in a very short time national notoriety. We had over 75 schools, either we went to or they visited us, looking at how we actually are doing things over at Hofstra, or the Zucker School of Medicine. So at about 5 or 6 years ago, I, throughout this time, went to maybe 3 or 4 invited talks a year around the country talking about curricular reform, transitioning from lecture-based to more student-centered curriculum. And I would be invited to speak to schools that are opening, such as University of Texas, Dell, 6 years ago, Texas Christian University, just this last summer, some osteopathic schools, UIW, down in San Antonio, and started to become recognized nationally. I was offered a position with Hofstra matched about 5 or 6 years ago, and I became an associate dean. So, I think it was very, very organic. I don't think anybody ever gave it any second thought that I was an MD or a DO. I think that Dr. Smith and Pat and Ellie, the people that I answered to, just saw that, I was gaining a national reputation. They saw value in what I was doing at the school, and they wanted to retain me. And I'm blessed to be here and, really give them 100% effort in that, and the students, most importantly.
I can personally say the value of DPC is unrivaled, especially in your preclinical years where you've been studying from a book, from professors, and you haven't had that clinical experience yet. And it's a really good resource to give us experience before we go see real patients.
Well, that's one part of it. But the other part is academically learning how to learn. I can sit and lecture to you. So let me just give you this very funny anecdote of, how I transitioned from pathology to a associate dean of an academic, case-based, this type of, expertise in case-based learning. There's a transition there, and it all started with an aha moment. I always used to think that you can't learn pathology without me lecturing to you, letting you know what I think is important, and then regurgitating that back onto an exam. So I think that that's the way I kind of thought that medical students learned is I lecture to you, you regurgitate back to me, very traditional way. It turned out that, the very first class, that I took over for, when I inherited them, I gave a very, very beautiful floor show. The students loved what I was doing. I was using all the same materials as my predecessor. I had probably about 230 out of 300 students show up for my sessions, whereas maybe 15 students showed up for my predecessor session. So, everything was working great. It came time for the class that actually took complex at that time, and the class that I inherited actually did worse on the pathology part of the boards than my predecessor, who they never showed up for. It was a very aha moment. So my mentor, sat me down and asked me the question, why do you think this happened? And I couldn't understand why. If you guys showed up, if I used the same readings, the same questions, the same everything, and you guys showed up for every session, then I don't know why you did worse. I mean, you guys didn't show up for anything, for my predecessor, or not as much for my predecessor, but yet you did better with them. And I'm just curious, do you know why that happened?
Oh, I'm not sure.
Well, what ended up happening was, I'll Socratically go through this with you. I'll give you a little taste of what I put my Zucker students through. So, if I said to you that learning happens at home, learning does not happen in the classroom, then all the students that didn't show up for my predecessor had to learn all of pathology on their own. Dare I say, they had to do the heavy lifting on their own. The students that showed up for me thought they knew everything about pathology because they were reinforced that in the classroom and on their exams, that they didn't study for pathology as hard for their boards as my predecessors, who had to do it because they never showed up for it. It was an aha moment in my career. It was an aha moment that you as a student don't need me to learn material. You need me to be an application, to give you value added to your pathology, to give you critical thinking, to ask you questions, but you don't need me to regurgitate Robbins back to you. And it was an aha moment, and that's where my career really flourished. It blossomed into eventually an expert in student-centered curriculum.
Mm-hmm. Yeah, and that explains perfectly why I might understand something in class when learning it, but then when I go home, it's like I never learned it at all. So earlier we talked about how the USMLE is becoming pass-fail. How do you think that this affects osteopathic students?
So back then, the boards were looked at as essentially vehicles to become licensed. That was it. So back in 96, whether you took the USMLEs or whether you took COMLEX, you needed a vehicle to become licensed. The only thing North Shore really required out of us is to hold a medical license by the time that you were a second-year resident. That was it. So when I went for my interviews and when I went for my showcase rotations, the only question I was asked is, did you pass step one? That was it. Did you pass step one? Are you planning to take step two in time? Are you going to be licensed on time? That was the only thing they were concerned about. Because if back in those days, if you were licensed, you wouldn't be able to become or stick with a residency in your second and third year. So whether you took the COMLEX or whether you took USMLE, it made no difference because the license is exactly the same. The medical license for the state of New York and all the states are exactly the same. It's licensed to practice medicine and surgery in the state of New York. So no, but what I would say is that I think this is my personal opinion. I think it's a wonderful thing that they got away from, the numerical score. I think, it helps MDs and DOs. Listen, the top 5% are going to have no problems no matter what. But for the vast majority of students, I think it really puts the emphasis not only in your knowledge, but it also puts the emphasis on your integrity, on your work ethic. It puts on your attitude. You have full control over how you want to showcase yourself. The other thing it does is you're going to have to critically think about, hey, what type of student am I? What type of application am I going to have? I mean, am I really going to showcase at Mass General? Or, do I need to make sure that I start showcasing at places that I have a legitimate shot of being competitive for? I mean, I'm speaking very bluntly, very, very frankly, but it's really going to put the emphasis back on the student to really think about what their strengths, what their weaknesses are, where they want to practice medicine, what type of medicine they want to practice, what type of institution, what the culture of that institution is, what your culture is, do they match? all these other things are going to be much more important rather than just a strict numerical score. Because to be perfectly frank with you, somebody with a 260 USMLE score and somebody with a 245 USMLE score, I have no idea what the difference is. I just don't. It's the exact same type of student. In fact, I'll even go one step further. I'm not really sure what the difference between an average score in the USMLE is a 230, let's say. I'm not really sure what the difference is between a 230 and a 260, right? So, because that really doesn't talk about all the other intangibles that are going to make you successful. So, me personally, I think it's a wonderful thing. I think it's going to liberate in some ways students, but most importantly, it's going to liberate medical education, because medical education will stop degenerating into essentially Kaplan type programs just to get their students to do well on boards. And medical education is going to start thinking about, really thinking about novel, creative ways of having their students be exposed to patients earlier on, maybe research. We're going to rethink education. It's my opinion. I don't know this for a fact, but I think it's a wonderful thing that we're getting away from a score.
So the last question I have today is regarding the COVID-19 situation. I understand things are still changing from a day-to-day basis, but what advice do you have for the medical students, especially the 2021 and 22 class, for the uncertainty they have in the future with regards to things like rotation cancellations, board testing cancellations, things like that?
Yeah. There's certain things that we can control, and there's certain things that we can't control. And there's no sense of spending one extra second in something that you can't control. If you waste one bit of effort, of worrying, of energy in meditating over something that you can't control, then it's time wasted from something that you can control. So that is a very important concept that I need to get across to you. You can't control if a testing center is going to be open or not. You can't control what the policy of a medical school is going to be, whether you're going to be able to rotate or not, or what type of rotations you're going to be on, or if you are able to rotate, what you're going to be able to do. A lot of that stuff is out of your control. In some ways, it's quite liberating. If it's not in your control, it's not in your control. And the other point is that it's not only affecting osteopathic students, it's affecting every medical student. So you're in the same boat. In other words, our students over at Zucker are wondering the same exact thing you're worrying. When are they going to take their boards? What is showcasing going to look like? What are their rounds going to look like? What is match going to look like for next year? How is that going to get done? So you're all in the same boat. You're all equal, because all the circumstances that your guys are worried about are completely out of your control. So I wouldn't give it a second more of thinking about it or worrying about it. That's the first piece of advice. The second piece of advice that I would give is I would meditate on what you can control. At the end of the day, it's about falling in love with the content. It's about learning medicine. So if you have this time outside of rotations, you should be spending it on, I know maybe I gave dilated cardiomyopathy a little bit of short shrift in the first 2 years of medical school. I really need to learn this. Or, maybe I thought I understood nephrotic versus nephritic syndrome and glomerulonephropathies, but do I really understand it? I think that the advice that I would give you guys now is to really take time to formatively assess yourself in an honest way. What do you know? What don't you know? How can I get better? Academically? How can I get better physically? How can I have better relationships? Everything that is in your control, I would try to do it with excellence. And that would be my second piece of advice.
Thank you so much, Dr. Elkowitz. Is there anything else you would like to say?
I just wanted to wish all the DO and MD students, I'm sure that you have a mix of students listening to this, and certainly all the undergraduate students that are thinking about pursuing a career in medicine. This is a great time to become a physician. I think there's no better profession in the world, MD or DO. I think that you're very, very lucky to be able to apply to these institutions. And just remember, everything is in your control. And I think that if you approach something with a really good attitude, defined as working with diligence and a smile, and trying to understand that the patient is always looking to see what you're learning as far as content, I think if you keep that in mind, you're going to have wonderful careers. And I envy you a little bit. I'd love to start over. It's a wonderful time in medicine, and I just wish all of you guys a tremendous amount of good luck.
This concludes our 5th episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there is someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea, OMS 3. Thank you guys so much for listening to Do